Hi, well, welcome everybody. My name is Chad Sievers, and I'm your webinar moderator today. And today's webinar is on substance use and trauma exposure, an adolescent perspective. I'm going to go over a couple of housekeeping announcements first, and then I'll introduce our speaker here. If you'd like to ask a question during the presentation, please use the question feature, which is on the right side of your screen, and we'll try to answer those. We'll have some time at the end of the presentation to answer questions if you have them. If you are interested in earning a CEU, just be sure to stick around to the very end. We'll have a code that's given out on this webinar. If you're watching with a group, just let me know who the person originally signed in as. And if you happen to be watching this at a later date on our YouTube channel, we only are able to give out CEUs for live webinar attendees. So are we going to be recording this webinar, and we'll upload the presentation to our website. And if you like trainings like this or announcements, be sure to check out our Facebook page where we frequently post about webinars and other training opportunities. So I'm going to introduce our speaker, Dr. Nihit Kumar. Dr. Kumar completed his medical school in India and moved to the University of Arkansas for Medical Sciences to pursue his psychiatry residency. He has since completed a double fellowship in child and adolescent psychiatry, as well as in addiction psychiatry, and is board certified in all three specialties. His particular area of interest lies in treating adolescents and young adults with comorbid mental health and substance use disorders. He also runs a buprenorphine clinic treating adults with opioid use disorder. He's also involved in research and recently published a paper on the effects of childhood trauma on retention in patients on buprenorphine. He volunteers his time at the National Alliance on Mental Illness, the Arkansas chapter, where he is currently serves as the president. So I'm going to go ahead and turn the presentation over to Dr. Kumar. And
all right, thank you, Chad. And thank you all for being here. I really appreciate the time and effort you spend to take care of our kids and adolescents. All right, so I'm going to start with my learning objectives. We will talk about what it is about adolescents that makes them so vulnerable to using substances. We will talk about the relation of trauma and adolescent substance use and some research articles related to that. And then we will discuss the association between how adolescents perceive substances to be in terms of their effectiveness or risk, and how does that affect their use in adolescence. And then finally, we'll move on to more of the treatment and the management strategy. I'm trying to move this forward. Okay, all right. So when you look at adolescents, a lot of things are going on at once. It's a time of extreme changes. They're going through puberty. Their brains are still developing. There's a lot of synaptic pruning and myelination that's going on. And a teenage brain is very different than an adult brain. The teenage brain doesn't completely become an adult brain until the early 20s. And so that the brain changes are still going on. If you look at their different stages of change, teenagers are usually in their identity versus role confusion stage, which means that they're trying to figure out who they are. They're trying to experiment, and they're trying to take risks and test limits. And all of that goes along with increase in risky behaviors. In terms of changes in social roles and social context, now they're starting to date, get into relationships. Some of them may get their driver's license, which increases their mobility. And then they're transitioning to high school and thinking about going to college or getting a part-time job. And all of those experiences dictate their exposure to, using substances. So if you look at the basic reward pathway, when you use substances, you feel high, you feel good. And how does that work? Well, there's a nucleus, a group of neurons in your midbrain that's called the ventral tegmental area, which have dopamine projections. And dopamine is one of the neurochemicals involved in this reward pathway. The dopamine projections are to the nucleus accumbens. And this pathway is the reward pathway. You can see in the slide, there's a prefrontal cortex right in the front part of your brain, which inhibits some of these impulses. So essentially what happens is when you use a substance, you feel good because of the dopamine pathway, but you have the prefrontal cortex, limiting your impulses, limiting, providing more inhibition. What happens in adolescence specifically is the reward pathway is fully developed. The gas is all there. Compare that to the prefrontal cortex or the brakes of the brain, it isn't fully developed. So there is a delay in maturation of the inhibitory systems in the brain of a teenager compared to the reward pathways. And what that means essentially is they have all the gas, but no brakes. And so that leads to them increasing the reward-seeking behavior and risk-taking behaviors, including substance use. There is also a lot of research that shows that adolescents have lower sensitivity to the negative side effects of some substances. For example, they are less intoxicated sometimes when they drink alcohol or have negative side effects from alcohol. And so they can consume huge quantities of alcohol or marijuana or other drugs without having the same negative side effects. And unfortunately, that leads to the higher quantity of drugs leads to more neurocognitive effects on their brain. So I put this slide in just to show you that the brain of a young kid compared to a school-age kid, compared to a teenager and someone in the early 20s are different. The percentage of gray matter and the white matter is different, and the brain is still forming. So how do we diagnose substance use disorders? Well, as anyone else, we use the DSM, and the DSM-5 criteria has 11 criteria, and they're kind of grouped into categories. So one of the criteria, the top 4 criteria are about, losing control over substance use. So when people use substances, they cannot control their use. And so cravings, a lot of times spent, unsuccessful desire to control use, and substances taken in larger amounts than intended are all in that category. The next few categories relate to social consequences. So substance use results in failure to fulfill major role obligations, causes social interpersonal problems, or reduction in social recreational activities. And then the next 2 criteria, 8 and 9, move on to more of physical problems, where substance use is more physically hazardous or dangerous. And then the last 2 categories are more related to their biology, where they can develop tolerance to a particular substance or withdrawals when they stop using a particular substance. Now, as you can see, you only need 2 out of these 11 criteria for someone to meet the criteria for a substance use disorder. And you can replace the word substance with any substances. For example, it can be an alcohol use disorder, or a cannabis use disorder, or marijuana use disorder, or whatever. And you're in the mild category if you have 2 or 3 of these symptoms. You're in the moderate if you have 4 or 5. And if you have more than 6 symptoms, then you're in the severe category of substance use disorder. So for the longest time, addiction has been thought of as an adult disorder. We always think of, people in the 30s or 40s or 50s having addiction. We don't usually think of adolescents as having addictions, right? Well, this is a great slide from NIDA, which shows that the addiction to tobacco, cannabis, and alcohol. And back then, when this slide came out, we were still in DSM-4. So it says, on the left side of the graph, the y-axis says percentage in each group who developed first-time dependence, because we had the abuse and dependence at the time. Well, kids between age 12 and 20 were the ones who were getting the most dependent on tobacco, cannabis, and alcohol. And so this addiction is really a developmental disorder. It spans the entire lifetime. This slide shows you the percentage of past year initiates among kids who've never used, or people who've never used. So you can see someone who's never used an illicit drug in their lifetime. What is the age that they first start using drugs? Well, it starts pretty early on, around age 12 to 13. In my clinic, sometimes they start even earlier than that. But as you can see, the peak age of initiating any illicit drug use is between 14 and 20. So that is the age that a lot of times you guys deal with and have to be careful on whether they have started to use or not. Now, because adolescents can consume large quantities, those drugs have on their neurodevelopment and can increase the risk of addiction. Now, due to these neurocognitive deficits, and we'll see some in the few slides coming ahead, how using drugs can delay their social maturation and their academic milestones. So you can clearly see how substance use at this particularly vulnerable time in the adolescent's life highlights the importance of early intervention. Just to give you some perspective on the numbers of how much substance is out there, if you look back from 1925 all the way to 2013, alcohol is still at the top. The red line, the top red line is just alcohol drinking, and the kind of the middle red line is alcohol being drunk. And these are percentage of high school seniors. Marijuana is lower, but as you can see in the past few years, use of marijuana has been going up. And around 2009, 2010, marijuana use has now crossed over cigarettes, which is in the black line. I put this slide in just to show you the prescription opioid abuse, and this is not just limited to teenagers, but anyone. When we think of kids getting drugs, we always wonder where do they get their drugs from, right? Well, a lot of people think they get it from the drug dealers. On the left pie chart, you can see the percentage of kids or people that get their drugs from drug dealers are only 4.3. Most of the times, majority of the times, about 54% of the time, they get it free from a friend or relative. So that means these kids are getting these drugs, especially opioid pain pills, from everywhere. It's available in schools, it's available in their homes, it's available in their grandparents' closets. And so we have to be careful as a community to make sure that our drugs, especially dangerous drugs like opioids, are locked up or kept safe. In terms of gender gap has been narrowing, and so there are studies that have shown that more and more girls are using drugs compared to boys. One study showed that more 8th grade girls had tried alcohol compared to the male counterparts. Now, African Americans in general have always had lower use of drugs than Caucasians, including tobacco, and Hispanics are kind of in the middle, but for some drugs, their rates could be higher. A lot of times, kids who have been using drugs have other co-occurring psychopathology. In fact, majority of the kids that have been using drugs have some other comorbid diagnosis. Some of the conditions that most commonly associate with substance use disorders are behavior problems like conduct disorder, mood disorders, depression, anxiety, ADHD, and physical and sexual abuse. So that leads me to talking about traumatic stress that you all deal with, and you are better at this. The definition I found about traumatic stress is it doesn't just involve physical and sexual abuse, but it can also involve a actual or threatened assault, abuse or injury, witnessing severe violence or death, repeated or extreme exposure to aversive details, and unexpected or premature death of a primary caregiver. And again, just to give you the numbers, between 50 and 62% of youth are exposed to at least one traumatic event in their life. That's a huge category of stress to have in their youth. Now, how does the trauma exposure and risk for SUD or substance use disorder relate? Well, there's plenty of studies that show a relation between early childhood traumatic event, including the study that I published, and these people going on to have substance use problems later in their lifetime. Well, we see the same pattern in kids. So teens with physical or sexual abuse or assault were 3 times more likely to report past or current substance use than those without a history of that trauma. Similarly, youth with multiple traumatic victimization, and a lot of our kids have this polytrauma or complex trauma, as we call it. Those youth with complex trauma are 2 to 5 times higher at a higher risk for developing substance use disorder. And if they go on to develop PTSD, the risk is even higher. So PTSD in adolescents is associated with 3 to 14 times greater risk of substance use disorders. Now, vice versa, if you look at kids who are in substance abuse treatment, 55.5% of them have experienced at least one traumatic stressor in their life. And there are studies after studies after studies that have looked at this correlation. What I've seen more, the pattern is studies have looked at the correlation between early childhood trauma and adult development of substance use disorder. But this was a very nice study that recently came out. This was August of 2016 by Carliner, and this was a group in Columbia, New York. What they looked at was exposure to potentially traumatic events before age 11 and the risk of development of substance use problems in teenagers. And they had a pretty big sample. You can see it's close to, I mean, the sample is 9,956 kids. And what they compared was risk ratios between the group with no potentially traumatic events compared to 1, 2, or 3 different potentially traumatic events. And you could see a pretty linear relationship between the number of traumatic events that a kid has before age 11 and the risk of using substances there. So we have a pretty clear interplay between trauma and substance use. So what are the theories behind this? Well, trauma could be a risk factor for substance use development, right? There's a self-medication hypothesis, which says, well, if someone has a trauma, they have a lot of distress, and so they use substances to manage that distress and numb their emotions, to deal with their trauma. The problem is exposure to trauma reminders during treatment can increase drug craving, which makes treating their substance use even more difficult. And on the other side, substance use could be a risk factor for trauma. You see a kid with alcohol problems, and they get drunk, and they have a sexual assault, or they're walking home from a party while using substances, and they get into a vehicle accident, right? So substance use itself could be a risk for developing trauma. And kids or teenagers who generally use substances may be less likely to cope up appropriately with a traumatic event due to pre-existing psychosocial impairments. And so trauma and substance use can be a factor in treatment of either of them. These are great posters from SAMHSA, which says, well, 2% of middle school students drink. These are kids between ages 12 and 13, compared to 11% of junior high students. Compare that to 25% of senior high students. By the time they go to college, 60% of them drink. And it's kind of hard to read that, but you could see how drinking affects their grades. For example, the little book that says F, the line below that reads, students who binge drink, which means 5 or more drinks per occasion, are 3 times more likely than those who don't drink to get mostly D's and F's on the report card. And we'll look at some of these in detail more. All right, so this slide shows you the alcohols on the top, and then you can see marijuana, prescription drugs, inhalants, and different kinds of drugs, right? And how does that relate to high school students and their grade performance? And this data is from the Youth Risk Behavior Survey, which was done in 2009. The way to read this is if you take the top left graph, the current alcohol use. Well, 32% of kids who are drinking alcohol currently are making mostly A's. Compare that to 62% of kids who are drinking alcohol currently who are making mostly D's and F's. You can see there's a very clear correlation between poor grade performance in school and substance use. Similarly, kids are very active in extracurricular activities sometimes, and you could see the rate of correlation between them using alcohol, cigarette, or illicit drug in the past month and the rates of their participation in extracurricular activities. They're less likely to participate when they are more involved with using substances. Dropout from schools. Again, you can see that kids are more likely to drop out from school when they are using substances compared to kids who don't. So what are the risk factors for kids developing substance use disorders? Well, there's always going to be an individual genetic factor. If their parents or grandparents, the people in their families have a substance use problem, they are genetically at a higher risk for developing substance use disorders. But there are other environmental factors, and we can group those factors into different community factors, family factors, school, and individual factors. So community factors are things like, well, if a community has, if it's a a low socioeconomic community with poor neighborhoods, dense populations, low monitoring in public places, those factors don't bode well for the community. The other angle to look at that is a lot of those communities have a favorable experience of using substances, and that can lead to kids getting earlier into using substances. There are family factors. If people in your family, adults in your family are using substances, what that means is, well, there's substances available readily in the house. 2, parents are modeling substance use and favorable attitudes around substance use to kids. And 3, that there's a genetic component there too. Well, if the parents are using substances, the kids are at higher risk of using substances too. And then parents who typically use drugs and alcohol tend to be more likely to neglect the needs, the emotional and the social needs of their children. And so children are less monitored and they kind of do things on their own. There are school factors, which says low academic performance or less kind of attachment with schools. Essentially what that means is you don't find the role of being a student productive or effective. And so low attachment to schools are directly related to using more substances. What that leads to is if kids don't enjoy going to school, they're going to skip school and they have a lot of free time on their hands. And so that increases the risk of involvement with deviant peers and using substances. And then there are individual or peer factors. There are plenty of studies that have shown a direct link between the number of peers that use substances and social groups of deviant peers that enhances someone's risk of increasing substance use early in life. There are protective factors, including high intelligence and resilient temperament, that is protective against substance use. Social, emotional, and cognitive competence enhances their capacity to deal with stress rather than depending on using drugs and alcohol. More opportunities for pro-social involvement, like involvement with their families, family events, their church group, team sports, all of those things help. Recognition for positive involvement, that means parents in the community providing positive feedback for whatever they're doing, and then high levels of bonding and healthy beliefs and standards for behavior. So all of these factors predict less likelihood of substance use in teenagers. So what do we do about kids who are starting to dabble in using marijuana or alcohol or cigarettes? Well, a lot of these kids do not have the appropriate social resistance skills. And what that means is when their friend asks them to smoke a joint with them, they don't know how to say no. And so social resistance skills helps develop these saying no skills. Normative education is where, I ask a teenager of mine in my clinic, hey, how many kids in your school do you think smoke marijuana like you do? And they say, well, everybody. Well, that's not normally true, right? From the data we have nationally and statewide, we know that not everyone uses drugs. And so being aware of those data and being able to show them to our patients can help normalize or not normalize how many kids use substances. Basically, you can tell them, you know what, not everyone at your school uses. Yes, there's a good group that uses, but maybe you're hanging out with the wrong group. Competence enhancement is when a lot of these kids do not have enough psychosocial skills or cognitive skills, and they may think of them as inferior. Maybe there are issues in their family, maybe there's a past history of trauma, and essentially the competence enhancement builds their own level of confidence in themselves, their level of their ability to say no to drugs. There are plenty of school-based prevention programs, which are universal, selective, and indicated preventions that target different kinds of groups. You can have a universal prevention for the entire school, or selective prevention for kids in detention, or indicated prevention for kids who have started to use substances. And I'll put the National Registry of Evidence-Based Programs and Practices slide. If you haven't heard of this, this is a pretty good website-based program. And what you can do is you can search on this website based on certain search criteria. like programs with effective outcomes, promising outcomes, different programs that have been implemented and have been kind of vetted by SAMHSA. And as you can see, if you plug in the numbers and you can get records, the Ascent program is pretty good for tobacco use and disorders and knowledge, attitudes, and beliefs, but some promising outcomes for social functioning and competence. And then on the right side of the column gives you more information about that particular program if you do want to implement it. These programs can be implemented in the schools, in an outpatient setting, in a residential setting. So essentially, there are plenty of programs that you can find. So SAMHSA has been big on promoting the SBIRT model, which is screening, brief intervention, and referral for treatment. So people who are not directly involved with substance abuse treatment, what they can do is they can do a much standardized way of doing screening using standardized screening tools. Once they've identified who's at risk and how much at risk, you can provide either no intervention or brief intervention or referral to more kind of specialized addiction treatment. So we'll look at this process a little further. CRAFFT Screening was developed. It was kind of like the CAGE questionnaires for alcohol for adults. So they modified that with CRAFFT, and so this is more appropriate for teenagers because the questions are more appropriate for their developmental level. And so essentially you start with asking the first 3 questions. In the past 12 months, did you drink any alcohol, more than a few sips, smoke any marijuana, or use anything else to get high? And that's it. Pretty easy to do, takes less than 15 seconds. And if you score a yes on any one of those 3 questions, then you go on to part B, which has the next set of 6 questions. It kind of gives you an idea of how severe the problem is, right? There are plenty of other screening tools. Now, what I tried to find out for this presentation was, are there screening tools that can screen for both, trauma symptoms as well as substance abuse symptoms? And I only found one. That was the Global Appraisal of Individual Needs, or the GAIN short screener. Takes 3 to 5 minutes to do and assesses questions for both the trauma perspective as well as the substance abuse perspective. But there are plenty of other screeners for alcohol and drug use disorders. You can always drug test. In fact, in our clinics here in Little Rock, we have started to implement the quick urine immunoassays, the dipsticks as you call it. It gives you a result back from the urine sample in less than 10 minutes. Pretty easy to do, and that has vastly expanded our understanding of substance use in this population. So you can, the urine drug tests are the easiest to do, get a result pretty quickly, but drugs can be found out from blood, sweat, saliva, or hair. And then when you start to do the drug tests, you have to understand how drugs work. Not every drug can be detected at the same time. So I put this slide in just to show you that drugs can be detected at different times. For example, if you take marijuana, which is a classic example. Well, if someone has smoked a single marijuana joint, it's going to be available or be in their system for about 3 days. So it can be detected for up to 3 days. But if it's a moderate use, you can go up and detect it up to a week. But if it's a long-term heavy smoker, marijuana can stay in your body for up to or more than 30 days. And similarly for other drugs, they have different half-lives and different times that they can stay in your system. And if you are doing immunoassays like we are doing in our clinic, you have to be careful about false positives. What that means essentially is there's a lot of other substances or medicines that can show up as the substance that you're trying to test. For example, if I'm trying to test for cannabinoids or marijuana, well, proton pump inhibitors or NSAIDs like ibuprofen can sometimes show up as cannabinoids. So you have to be careful of what other substances they are taking. Okay. All right. So we talked a little bit about screening and the screening tools, including CRAFFT. Well, once you've identified someone at moderate risk, you want to tell them something, right? And you all are already probably doing that. You're telling them, well, you need to quit smoking or quit drinking, and this can be harmful for you, right? Well, SAMHSA has developed a pretty standardized way of doing that brief intervention. And you can choose to follow it or not, but FRAMES is a perfect example of a brief intervention that literally takes less than 5 minutes to do. What this involves is giving feedback regarding their personal risk. And the important word is personal. If you tell a teenager, you're going to develop cancer because you're smoking cigarettes. Well, even though that might be true, they don't have cancer. They might not know anybody who has cancer. So they're not going to take that as personally as if you would tell someone who smokes cigarettes saying, well, your asthma would get really bad if you continue to smoke cigarettes. So make it personal. You have to emphasize their personal responsibility for change. Tell them, I can give you all the information you want, but it is only you who can make that decision to change. Don't be ambiguous. Provide them a clear advice to change. Tell them very clearly that you wish they would stop using. If they are interested, you can offer them a menu of alternative change options. You can agree to meet with them more regularly to talk about this. You can agree to get them to more specialized referral. And of course, while doing all of those, therapist empathy is really important. So you definitely want to empathize with where they are. And I usually start with asking my teenagers, what do you like about whatever substance you're using? What do you like about marijuana? What do you like about drinking alcohol? Try to get that perspective. And then build on that. Try to figure out what problems have they gotten into because of that. So if you use that approach, it may help better with them listening to you. And then last but not the least, you have to encourage their self-efficacy. A lot of times people use and they try to hide it and they don't want other people to know about it and they don't feel they can quit. And your job as their therapist or provider is to help them develop their confidence that they can change. Part of that involves picking up on little things that they've done successfully in their lives, like they've made good grades in school or they've managed to have a good relationship with their families, and work on that. All right, so moving on to more specialized treatment. So we talked about screening, then we talked about some brief interventions. What do you do when things are more severe, right? So we want to look at some treatment options. There are a lot of treatment options that's available, medications and therapy. And there was a meta-analysis that was done in 2008 that showed that no single treatment was superior to others. So it's not like, well, we should use one kind of treatment. Every treatment was effective. Treatment usually resulted in reductions in substance involvement and improvement in their psychosocial function. So we saw school improvements within 1 year. We saw improvements in family functioning within 2 years. And if you even just focus on one substance, it results in reductions in other substances that they may have been using. And what that tells us is addiction is not just related to one particular substance. It's a pattern of behaviors that is common with, it encompasses all the different substances. So when you work effectively with one substance, you're not just changing factors related to that particular substance, but you're changing the entire overall behaviors. And that leads to a reduction in other substances too. So the most common therapy for substance use in adults and teenagers is motivational interviewing. It kind of builds on the strength theoretical model of change. Essentially what MI conceptualizes is, well, people are in different stages of change. And these stages of change are fluid. They are not set in stone. And people can move between these stages from one day to the next, from 1 hour to the next. So pre-contemplation talks more about they don't think they have a problem with their alcohol use or their tobacco use. And so they, since they're not even aware of the problem, they're not even contemplating that change. Contemplation as well, the awareness of the negative effects have come in to the forefront. So now they're thinking, well, I like smoking cigarettes, but on the other hand, cigarette is causing me to spend a lot of money on it. There's some kind of negative effects. That's the contemplation stage. Determination or preparation stage is when someone decided, you know what, it's not worth using the substance or drinking alcohol. And so I really have to make an effort. And so they've started to talk to their providers, their therapists, and figuring out what they can do about it. Action is when they've actually started to make that change, whether they've started to engage in therapy, whether they've started to take medications for the substance use, That's the action phase. And maintenance phase is when they've quit using substances and now they're clean of it, but they're trying to maintain in their recovery. So as you can see, especially in the first three, the pre-contemplation, contemplation, and determination, that's the crucial part. So what motivational interviewing does is, it essentially is a technique. It's nothing new. It's not a new kind of therapy. It borrows from a lot of different therapy models, and it's kind of really a package of those therapy techniques. It uses skills like reflective listening, open-ended questions, avoiding any arguments or discrepancy, any arguments or resistance, and ways to manage that resistance or manage that discord. And then what ends up happening is you start to create that little discrepancy, because we know that patients with substance use are already ambivalent. If they're in the contemplation stage in particular, we want to do everything we can to move them to the next stage of change, which is the preparation stage. And so using MI techniques, you can build on those ambivalent thought processes that they're having and work with them to move them along towards their goals. CBT is very effective for substance use. What CBT sees as is the substance use is a learned behavior that are initiated and maintained by environmental factors. So there could be settings or situations or people that can act as triggers. And so what CBT does is it helps identify those triggers and then work to change those cognitive thought processes to prevent substance use. So there are components like psychoeducation, emotional management and problem-solving skills, and finally the cognitive restructuring of cognitive errors. We use a lot of TF-CBT in our clinic for substance using for youth with trauma. But research doesn't show that TF-CBT is very effective for substance using youth. But there are other CBT-based strategies that we can use, specifically the trauma affect regulation, the target trauma affect regulation guide for education and therapy. This is a psychobiologically based present-centered therapy that addresses not just affect regulation, but the automatic stress reaction. And this has been validated for substance use treatment. There are a lot of other CBT-based strategies or therapies that can be used. I'm going to jump right to the last one, which is seeking safety, and it was developed with veterans with PTSD and comorbid substance use. And there's been a few, I've read at least one paper on using seeking safety for adolescent girls with trauma, and that has shown some effects on reducing their or improving their outcomes for their PTSD and some outcomes for substance use. But as you can see, there are a lot of other models that can be used for this comorbid population. Contingency management involves providing rewards, immediate feedback. This builds on, well, if you do something really well, you get an immediate positive feedback. And what that does is that positive feedback keeps you motivated to continue to do well. So what contingency management ties is providing rewards in terms of, usually it's monetary rewards. So you get a dollar amount for every time you have a clean urine drug screen. And it's incremental. So you start with a low dollar amount for the first negative urine drug screen. And then the second time you come in, you have a clean urine drug screen, you get a higher dollar amount. And then third time you get a higher dollar amount. So it continues to work on reinforcement, positive reinforcement. So people can use this technique to reduce the risk of them using substances and keeping them motivated. Now, a lot of these techniques can be combined. So very frequently, contingency management is combined with CBT or motivational interviewing. It's very good at retaining patients, but studies have been sparse. But those studies have shown very promising results. And finally, well, not finally, but family therapy. So adolescents don't exist in a vacuum. Obviously, their families, their schools, their peers, and their community are all involved. And a lot of those environmental factors are the factors that initiate or maintain an adolescent's use of substances. And so targeting the family and the community makes complete sense. And there's a lot of these therapies, including adolescent community reinforcement approach, multisystemic family therapy, multidimensional family therapy, or brief strategic family therapy that deals with not just their trauma issues, not just their family dynamics, but also their involvement with risky behavior problems and risky substance abuse. We know that family is important for recovery, and so there's a lot of manualized treatment in these therapies that can be implemented. A lot of these involve very intensive work with therapists, sometimes even going to the parents' homes and providing therapy there, sometimes multiple times a week. But this can actually, investing in the short term with very intensive treatment can actually have much more better results in the long term. 12-step organizations. So 12 steps are more, adult-based. We've always had 12-step communities. There are 12 steps that are available for adolescents. The problem is in states like Arkansas, the number of 12-step organizations for youth specifically are limited. But this is a very commonly used and cost-effective way of getting kids the support they need. They hear their peers talking about their experiences. It can be widely available and easily accessible. And having a sponsor in a 12-step program is really instrumental in better success. But the problem, again, for some of the youth are the negative effects from attendance. What if they go into an AA or NA group and they meet other peers who are not very honest in their recovery, and so they kind of start to attach to those peers and continue their substance. That's one problem. Age composition can be another problem where we don't have a lot of youth 12-step meetings, so they start to attend regular adult 12-step meetings and they don't feel connected to those adults. Sometimes that could be a problem. Sometimes these kids do not have the cognitive capacity to understand the program concepts. And sometimes, which is common in 12 steps, not everyone likes every 12 steps. You really have to try a few before you really find some program that can be very effective. So it's a process of trying to find out a program that really fits what you need. And so moving on to, we just finished talking about the different psychotherapy or therapy aspects of treatment of adolescent substance abuse. There's a lot of psychopharmacology of substance use that I wanted to touch on because a lot of times my patients have questions about, I'm smoking marijuana. Is there a medicine I can take for that? And if you're not aware of the medication strategies, you're kind of in a bind in what to tell them. So Kaminer, which you've seen this author in a lot of my slides today, he's big in substance abuse treatment. And so he came up with 4 strategies pharmacologically in treatment of substance use disorders. Well, one is to make the substance administration aversive. For example, when someone takes antabuse for their alcohol dependence. Well, when you take this medicine called antabuse, what it does is if you drink alcohol while you're taking this medicine, you tend to get very sick. And so what it creates is a negative reinforcement that prevents you from drinking alcohol. And so that's one strategy. The second strategy is to use agonist medications with similar mechanism of action, which can stabilize the patient and reduce symptoms of withdrawal. For example, in my buprenorphine clinic, I use buprenorphine to treat patients with opioid use disorders. These are patients who are addicted to heroin or pain pills like hydrocodone or oxycodone. And so I'm substituting that with buprenorphine, which has a much longer half-life. Now, buprenorphine is itself a partial opiate. So it helps reduce their cravings because it helps them some with that opiate effect. But what it does is it stabilizes the patient so they have more time to improve their life. They have more time to engage in treatment. So that's a strategy of using agonist medications with a similar mechanism of action. There are medicines that can block the reinforcing effects of drugs. For example, naltrexone for opiate use disorder. So naltrexone, what it does is it's an opiate antagonist, which means that it binds to the same opiate receptors, but instead of having any effect, it has the opposite effect. It has no effect. So when someone takes naltrexone, as long as the naltrexone is in their body, if they take an opiate, it won't have any effect. That's one way of doing things. And then there are medications that can reduce cravings and withdrawal. For example, acamprosate or naltrexone for alcohol use disorder. These medications have been shown in research studies to reduce overall cravings and withdrawal effects. So again, you can see there are different strategies that we can use medications for. So I wanted to go over this part quickly and just make you aware of what's available, what's out there. In the overall substance abuse field, there are only about 13 medications that are used. That's it. And 5 of them are for nicotine. So nicotine patch, gum, lozenge, and inhaler, and a nasal spray. These are 5 of those 13 medications. So we don't really have a lot of medications available for treating substance use. We can definitely use a nicotine replacement products for someone who is trying to give up smoking cigarettes. And then Zyban or Wellbutrin has some effectiveness in reducing addiction to nicotine. For alcohol, we have antabuse, as we just talked about, and then naltrexone, which we talked about being an opiate antagonist, but has effects in blocking the reinforcing properties of alcohol. And then finally, acamprosate, which has a glutamate mechanism that helps reduce the craving. For marijuana, we don't really have good medications. There is some evidence on using the pill form of marijuana, which is called Marinol or Dronabinol. So there's some evidence for that, but in larger studies that has not shown to be very effective. There is growing evidence on the use of N-acetylcysteine or NAC, NAC, for marijuana use, especially in adolescents. So a couple of studies have shown that it can be effective, but again, the evidence is not very rigorous. And then for adult marijuana use, gabapentin can be effective. Now for opioids, we have very good medicines to treat them. So methadone is a full opiate agonist that can help with their abstinence syndrome, eliminate their cravings, and block the euphoric effects of self-administered opioid. Methadone can only be administered in a federally controlled, approved treatment facility. So it kind of restricts access. And usually for methadone treatment, you have to come in once a day in the morning to be dosed in the clinic, and then it continues. And then on the weekends, you get some take-home bottles with you. But methadone can be an effective treatment, and youth ages 16 and above are eligible. Now they have a slightly different criteria for eligibility for methadone compared to adults over 18, but it can be done. So to avoid the issues related to the regulatory control over methadone, buprenorphine is another medicine, and again, it is approved for use in youth over 16 years for opioid use disorder. And as we talked about, buprenorphine is a partial opiate, and so it kind of acts like any other opiate, but it's much safer to use, and it can be used in any outpatient clinic. Now, the providers have to get a special DEA waiver for that, but using buprenorphine, it can be combined with group therapy or different other therapy modalities that is used. And you can actually see the patients once a week or once in 2 weeks or once a month eventually as they continue to do well. And so that concludes my presentation. These are some of my references. And now we have a few minutes that I can take questions for.
All right. Thank you, Dr. Kumar, for that really interesting presentation. So if you do have a question, feel free to type those in and we will answer those. We have a few minutes and got a couple of questions in here. So one person asked, are there any studies, or are you aware of folks who respond better to, I think they're asking about respond better to therapy? Is there somebody who is just geared to do better than somebody else and respond to therapy?
So if I'm trying to understand your question, there are therapies which are evidence-based, that people have responded to in rigorous clinical trials. Now, is the question more asking about if there are individual differences in whether they would respond to a particular kind of therapy over others? That is a very individualized question and totally depends on what characteristics the person has and what's the length of substance use disorder. So, for example, if someone's used substances for years and years, and they have really major neurocognitive problems with their brain, so it will be very hard for them to grasp the cognitive processes involved with, for example, CBT, to grasp those concepts. And so it can make treatment a lot more difficult for that particular patient. With teenagers, as I said, earlier, their brains are still developing, and sometimes teenagers lag behind in their cognitive skills. And so treatment should really be individualized. Once you've assessed someone, you can identify a particular kind of therapy that may work better for that particular person. And that's really a very individualized treatment choice.
Okay. Another question here is, what's been the biggest barrier in assessing for substance use? Maybe in Arkansas or just...
Right. Well, so one of the biggest barriers is, this whole shift in culture about thinking about addiction as not just an adult disorder, but really a developmental disorder. It starts very early on in life and can have lasting effects all through the life. And so we, as a whole community of providers, need to be comfortable talking to kids early on in middle school and high school, and comfortable in talking to them about the risks of substance use, their patterns of substance use, and the harmful effects of substance use. Part of what I think the other barrier is the training aspect. Not a lot of us have been trained in addiction treatment, and so we kind of feel sort of incompetent in, well, what if I ask them about a particular substance and they say, yeah, I've been drinking some alcohol or smoking some weed. Well, what then? What do I do then? Who do I talk to? So that's the other barrier, is when you don't know what to do, you tend not to ask those questions.
All right, thanks. So yeah, if folks have other questions, be sure to type those in. I'm going to advance to our CEU slide here. So if you're interested in receiving a CEU, just email me the code. And it's helpful if you tell me your first and last name. It just makes looking you up a lot easier. So if you're interested in CEU, the code is displayed there on the screen. Okay. Well, any other questions out there folks have? Yes, and someone has asked if the PowerPoint will be available for you, and yes, we'll send that out after the presentation today. Oh, somebody has asked, Dr. Kumar, is there a rise in, I guess they're talking about Arkansas here, is there a rise in any one particular substance use in Arkansas that you've seen in recent years, or?
Right. So if you look at the data, and marijuana is obviously on everyone's mind, we are very closely watching the marijuana with the more recent legalization issues. Compared to the past few years, marijuana use in Arkansas has been going up slowly. The other thing to point out is something called a perception of risk. What a perception of risk is how risky do kids perceive a particular substance to be. For example, how risky do they think drinking alcohol is compared to using heroin, compared to using marijuana, right? That's called perception of risk. So we are watching not only the trends of use of a particular substance, but also the perception of risk. And for example, for marijuana, the perception of risk nationally and in Arkansas has been going down steadily. The use of marijuana in Arkansas and nationally overall has been going up steadily. And so what that tells us is if kids perceive a particular substance to be less risky or less harmful, they're going to use it more. So to answer your question, for marijuana, the use has been going up. For opiates, pain prescriptions, it has been kind of stable. There's always those little fluctuations from one year to the next. But in the past 5 years, it's been a little more stable. So we're not seeing a huge rise in the numbers of opiate prescription use. Now, there could be a problem with how you do surveys. So just because I'm saying, well, the results haven't shown that doesn't mean there is more use. We just have to be careful of the way surveys are done.
Hey, thank you. So I'll just last call for questions. I know we're kind of at the top of the hour, and Dr. Kumar, I just want to thank you again for a very informative presentation. So maybe another 10 or 15 seconds. If you have a last question, go ahead and write those in. And if you think of something later, be sure to email me and I can pass those along. And again, if you are interested in receiving a CEU, just enter the, you see the code is displayed there on the screen, and send me an email and tell me your first and last name, and I'll get that CEU sent out to you. So Dr. Kumar, thank you once again for doing our webinar today.
Thank you. It was a pleasure.
Okay. All right. I'll leave the CEU code up there for a little bit, but I'll stop everyone's phone. All right. Everyone have a good afternoon.